Good afternoon. It's Barry Sarvat here and our MCPAP team. And we are very pleased to begin our clinical conversation session for today. We have a really nice topic to focus on, and just a few housekeeping things before we jump in. So, first of all, that we have our program on the fourth Tuesday each month, and we are looking forward to being able to have our next one on the fourth Tuesday, which is the 28th of April. So today, our topic is antipsychotic medications in youth, practical strategies for monitoring and managing side effects in the pediatric primary care setting. We offer CME as always, or actually not always, but we started doing it recently, and we're grateful to Mass General for supporting us with the accreditation for our CME program. The code you see up on the board and the instructions on the slide that you see, and the code for today is JOWGOT, and that it'll be in the chat as well. We encourage people to let colleagues know about the talk if you find it helpful. And hopefully you will. You can tell your friends and let people know that it's available for asynchronous, viewing on the MIPAC website in the toolkits and resources section, as will the slides be available as well. So you don't have to worry about writing everything down. We encourage questions, and we call it a clinical conversation because we want to be able to have a dialogue about sort of the material. So feel free to just liberally ask whatever questions come to mind as we go along, and we'll address them as we go along, or at the end, depending upon what your question is. And if you could take a few minutes to fill out the survey that you'll get after the seminar is over, we really appreciate ideas, for future topics and just feedback about how we're doing. Now I'm going to go ahead and introduce our wonderful speaker. Today we have Dr. Yosh Kaneko. Um, and he is a faculty member and a psychiatrist at Mass General and faculty at Harvard, of course. And he is the director of the Transitional Age Youth Clinic at MGH, and is also the site director for MGH within the MCPAP ecosystem. And so he is one of our own. And he is also on staff at Newton Wellesley Hospital and serves as the interim chief of child psychiatry there, and the director of outpatient programming. And he is also the director of Child and Adolescent Consult Liaison Service there as well. He is an instructor of psychiatry at Harvard. He did his undergraduate at Harvard, and he did his medical education at Yale University, and his residency at Brigham and Women's and Beth Israel, and his fellowship at MGH. With all of that, I'm going to hand over to Yosh, and we're looking forward to some good discussion today as well.
Great. Thanks so much, Barry. Let me just take a minute to share my slides, get them up on the screen here. Okay. Are they up now in a way that everyone can see them?
Yes.
Yep, they're up.
Great. All right. All right. Well, thanks so much for being here, everyone. And Barry, thanks for that introduction, and also for moderating the questions in the chat as we go along with the talk. As Barry had mentioned, today we're going to be talking about antipsychotics in kids and adolescents, and specifically about monitoring for and managing side effects that can come up with these medications. I'm going to spend a little bit of time talking about just kind of how common and prevalent they are. And actually, as I was digging into the data, it was even more common than I had anticipated it being. And then we'll go through and kind of review specific side effects and how we manage them in clinical practice. The goal of this talk is just to help everyone be more familiar with what to look out for. We know that one, a lot of these medications are being started in pediatric practices now, but two, even when they're started by psychiatrists or like in an inpatient setting or something along those lines, we know that it's pretty common for patients and parents to come to the pediatrician with concerns about symptoms that they're seeing and questions about whether they might be side effects from medications that their children are on. By virtue of being here, you're all familiar with MCPAP. I'll put in just a quick plug here, especially for those of you who are affiliated with our MGH site, that we do have openings to see kids for consultations. And so please feel free to continue to use us and call us, and we can get people in quickly to be seen for consultations. So why are we talking about antipsychotics today? One, as I mentioned, they're very common in clinical care and more common than I expected. So some CDC data, which is a little bit older at this point, but showed that about 1% of adolescents at any given time are on an antipsychotic, typically an atypical antipsychotic, the newer medications, which is a pretty huge number of adolescents, right? If we think about all of the patients in our care, all the patients in Massachusetts, all the patients in the country. And as I had mentioned, pediatricians are often the first ones to hear about side effects, right? So even if you're not the one who has started the medicine, we want some familiarity with what kinds of side effects these medications can cause so that we can help direct patients and families to the right resources in terms of managing them. So another important point about the antipsychotic piece is that even though they're called antipsychotics, in kids and in adolescents, it's only a very, very small percentage, something like 3 or 4% of antipsychotics that are being used to address psychosis, right, for primary psychotic disorders. And that means that a huge majority of antipsychotics that are prescribed are to target other symptoms or other underlying diagnoses. And so that 3 to 4% represents just a very small percentage of all of these medications that are in use. So just to quickly review the types of medications that we're talking about. So the most common ones that you see in clinical practice that are used in this population by age are risperidone and aripiprazole, or Risperdal and Abilify. So as you can see, the FDA indications for both of these are not that great, right? There's only 3 for each of them, 4 for Abilify. But again, they are both widely used off-label to target aggression, DMDD, behavioral issues. And so my guess is in your clinic population now, you have a chunk of patients who are on one or the other of these medicines. So those are the most common. But in children and adolescents, we also see some patients prescribed quetiapine or Seroquel or olanzapine or Zyprexa. Those are kind of in the next most commonly used category. And quetiapine is used often for sleep or for anxiety or for mood lability, sometimes as an augmenter for antidepressants. And olanzapine similarly is used for sleep and for agitation, occasionally used off-label in restrictive eating disorders. And then there are a number of other atypical antipsychotics that are less commonly used. I'm just going to mention them quickly here in terms of why you might see them used, and then kind of things to think about for each one. So Latuda, one of the newer ones, seems to have a better metabolic profile, meaning it's less likely to cause weight gain than some are other atypical antipsychotics, as is ziprasidone, Geodon. Um, Paliperidone, which is a metabolite of risperidone, is another one that you'll see sometimes. One of the major advantages of it is it can be given as a long-acting injectable. So patients can get an injection, depending on the type of injection. Sometimes it's a month, sometimes even as spaced apart as once every 3 months. Clozapine, of course, is the antipsychotic of choice for treatment-resistant schizophrenia. Um, so unlikely, although possible, that patients who are in pediatric practices will sort of go through enough trials of other antipsychotics to get there. But it is notable to bring it up. And then all of these ones that I've mentioned thus far are what are called atypical antipsychotics, meaning they're the newer antipsychotics. Haldol is still used. Um, Haloperidol is the generic, primarily for agitation, often in emergency room settings, but occasionally also for severe tics. So those those three slides have, the medications that you're likely to see. Again, risperidone and aripiprazole are by far the most commonly used amongst those, and the ones that we have the best FDA indications for in this population, as well as kind of the most clinical experience with and safety profiles for. Okay. So as I had mentioned briefly, the FDA-approved indications for using antipsychotics in kids and adolescents are actually fairly limited, right? We have it for schizophrenia, but we know that that's quite rare and typically has its onset in late adolescence or early 20s, right? Bipolar disorder, similarly. Um, and then they do have approval for use in irritability associated with autism. Um, but even with those three chunks, that still means that off-label use really is more common than FDA-approved use. Some studies show that 60% of antipsychotics are used off-label. That was conservative in terms of the studies I found. So, other studies have as high as like 80% of the use is off-label. So uh, it's not to say that off-label use is bad necessarily, but just to point out the gap between um, what we have FDA approval for and then in the real world prescribing what these medications end up being used for. And often the prescribing is driven less by diagnosis and more by underlying symptoms, right? So, um, and usually this happens after a number of other medications have been tried and haven't been effective. And so people get to the point where they'll use an atypical antipsychotic for a child with ADHD or a child who's aggressive, even when we're not totally clear on what the underlying diagnosis is that might be driving that behavior. Um, I starred sleep here because this is just a pet peeve of mine. But using antipsychotics for sleep is almost never, for me, like should never be the primary indication for using an antipsychotic, even though we do see these prescribed pretty frequently. We're going to talk in detail about the sort of side effect profile associated with these medicines and that trade-off between the risks and the benefits when we're using them primarily for sleep is just, in my opinion, not there. So I would really caution against using that, and try to go back and lean into other interventions that we have if sleep is the primary complaint. So if we look at prescribing patterns over time, um, what we know is that in the like mid 90s to the early 2000s, there was a significant increase in the rates of prescribing antipsychotic medications to children and to adolescents. Um, and this was in part driven by the introduction of all of these atypical newer antipsychotics that were um, in some ways safer than the older antipsychotics and easier to manage. And so we saw significant increases in the rates for targeting all of those symptoms that we were just discussing and being used off label for that whole cluster of diagnoses. Um, After that increase, there was a lot of concern that maybe we were prescribing these medications too liberally. And so then states and um, Medicaid in various states put in policies, often sort of requiring prior authorizations, to try to uh, decrease the rates that these medicines were used. And so then, as we got from the mid 2000s uh, into the 2010s, those rates um, came down a little bit, not back to necessarily where they had been before, but down from their peaks. And then from then until now, those curves have been more or less flat, um, meaning that we've kind of leveled out in terms of rates that these medications are prescribed for kids and adolescents generally. Um, it is interesting to note that when you look at prescribing rates for this data that's on the screen is for young children, so these are kids up to 7. Uh, of all of these kids who were on antipsychotics, only about half of them had seen a psychiatrist to get these prescriptions, and only about half of them had any other form of behavioral health intervention. So, like seeing an individual therapist or parent guidance or family therapy or even group therapy. Uh, for me, that data is pretty concerning, right? Like, I think almost for any medicine psychotropic medicine that we use in child psych, by the time we get to prescribing a medicine, my hope is that there is some other form of intervention going on. And certainly for antipsychotics, where the side effect profile is fairly unfavorable, to not have any other um, intervention going on speaks, I think, probably to lack of access in a lot of areas. Um, but also, if you are in an area where there is access, we really want these kiddos to be um, getting something else in terms of the treatment that they're getting. So a couple other things to say about prescribing patterns. One is we know that kids who have Medicaid as insurance are more likely to be prescribed an atypical. Um, and as I talked a little bit about those rates, like behind stimulants and antidepressants, antipsychotics are amongst the most uh, commonly prescribed psychotropics um, for kids and adolescents. And that overall, boys are more likely to be prescribed antipsychotics than girls. Um, Again, this likely speaks to their use to target sort of behaviors rather than underlying diagnoses. And we see a lot of kind of the um, behaviorally dysregulated kids uh, get put on antipsychotics. So we'll switch over now and talk through in a little bit more detail the side effect profile of these medicines. We're going to talk about them largely as a class, but then as we go through, we'll kind of break down within the class of antipsychotics which ones might be more or less likely to cause particular side effects. Um, the metabolic side effects and weight gain are the ones that we see the most commonly, and I'm sure that you guys see in your offices all the time. And so we'll spend the bulk of the time talking through those. But also we're going to talk about a few other categories so that you're aware of them if patients present to your office kind of complaining of these symptoms. So in terms of weight gain and metabolic syndrome, these are unfortunately fairly common in practice. And it's often not subtle, right? Like we are seeing kids gain 20 pounds, sometimes 25 pounds on these medicines, and crossing percentiles on their percentile curves on their growth charts, right? So uh, again, it can happen fairly commonly, it can happen fairly quickly. And we know from data comparing kids and adults that kids are actually more sensitive to metabolic side effects of these medicines than adults are. So I've separated the commonly used atypicals out here by sort of risk level. So olanzapine, clozapine, quetiapine, risperidone, I think about as the most likely to cause weight gain. Of those, olanzapine and clozapine even higher than risperidone. So if you have a patient in your practice who's on one of those medications, then we want to be particularly attuned to that risk with those medicines. Aripiprazole is kind of in this middle category where some patients seem to do okay on it in terms of appetite and gaining weight, but certainly other patients have put on pretty significant amounts of weight. It's a little bit more kind of individual patient dependent. And then some of these newer medicines, lorazepam and ziprasidone, are a little bit less likely, it seems, to cause weight gain. It can happen with both of them, but less likely than ones in the other categories. And so we might wonder, like, well, if those are like less likely, why don't we just start with those? But the issue is that a approval for those is lower. Um, B, what we know from clinical experience is that sometimes they're a little bit slower to work or a little bit less, they can be a little bit less um, powerful initially, so that when we are trying to, treat kids acutely and kind of manage um, a level of dysregulation that threatens their safety or threatens other people's safety, that also plays into kind of getting the symptoms stabilized as an initial step, and then subsequently figuring out, okay, is this going to be a sustainable medicine for this patient? So in terms of monitoring for weight gain and metabolic side effects at baseline, so before we start these medicines, we want to know what their weight is, of course, their blood pressure, get a fasting glucose, and get a lipid panel so that we have those as a baseline. Then at least 3 months in, we want to repeat those labs, so recheck lipids and check a glucose and an A1C at that 3 month mark. And then beyond that, we want to do it at least yearly to continue to monitor for the development of these side effects. I would say in terms of when we're most likely to see the pronounced weight gain, it's typically if we're going to see it, it's typically within the first sort of 3 to 6 months of being on a medicine. So we're particularly vigilant during that early period. And then we do want to continue, excuse me, continue to monitor moving forward from there. So in terms of interventions, you guys will know better than I, sort of interventions around uh, weight loss and or weight gain. But we will start with lifestyle interventions, right? So, and I often start with parents and with patients talking about this even before we start them on an antipsychotic medication, right? Because for general health, we want them to put those into place, but also we want to emphasize to them, like, look, this kind of weight gain and metabolic issues are a real risk with these medicines. And so the more that we can do early to intervene, the better. So we'll start addressing those. Um, if patients are putting on uh, dramatic amounts of weight and their symptoms have stabilized to the point where dose reduction is possible, that's a reasonable strategy. There's not 100% dose dependent relationship between with weight gain, but you know, in general with these medicines, the less that we can expose patients to, the better. And so, we can arrive that balance between needing clinical stability, of course, but wanting to have them on lower doses. Uh, if neither of those are effective, then we'll start to think about switching to a lower risk medication. So switching to, either one if they're in the most concerning category, like olanzapine or quetiapine, seeing if we can get them switched over to risperidone or Abilify, or even down to lurasidone or ziprasidone. That can be tricky, right? Because again, we want to make sure that we're doing everything we can to help keep them clinically stable as we try to address these side effects. Um, I typically do that switch, do that crossover as a kind of gradual cross titration. So, uh, meaning that they would be on both medicines for, a month or so as we gradually weaned down the one that was more likely to be causing weight gain and then titrated up the one that we would hope would be more sparing in terms of increased appetite and gaining weight. Um, Talk through some medication options. So metformin we use quite commonly to try to help curb weight gain. I would say that for patients who are on antipsychotics, metformin is probably better at helping to cap the weight gain rather than helping actually lose weight, right? They may lose weight through some of the other interventions, particularly lifestyle interventions, but metformin alone is unlikely to really help them shed, whatever amount of weight they've put on from the antipsychotic. Um, the GLP agonists, of course, have been everywhere, and we don't have yet direct data on using them in kids who are on antipsychotics or who have experienced weight gain through antipsychotics. But we do have some angles of evidence that make us think that this is likely to be an effective and safe intervention to make going forward. So in adults, we have good data showing that GLP-1s are safe and effective for adult patients on antipsychotics who have gained weight in helping them to lose that weight. Um, and there's data in kids and adolescents with obesity uh, who go on GLP-1s and that's safe and effective as well. Um, that's those studies are done with adolescents who have obesity, but that is not driven by antipsychotics, right? So we don't yet have the study that combines these two angles of evidence, but my guess would be that this is something that will be coming and that will, I hope, be more routine in practice. A whole separate question, of course, is getting them approved and covered by insurances and et cetera, et cetera. But I think that this is uh, likely coming down the road. So um, we're going to switch gears now and talk a little bit about movement disorders that can occur as a result of antipsychotic medications, um, starting with kind of EPS or extra pyramidal side effects. So for anyone who has to brush up on their neuroanatomy, which I did also, the pyramidal tracts are the tracts that carry signals from our motor cortex down through the pyramids of the medulla out to our muscles to control voluntary movement. And then the extrapyramidal system is the basal ganglia, the cerebellum, those brain regions that are more involved in posture, maintaining muscle tone, sometimes modulating voluntary movements. And we can see when dopamine is blocked in the extrapyramidal symptom, some of these neurological symptoms come up. So akathisia is the most common. Um, Patients with akathisia will describe sort of a heightened degree of restlessness and an inability to sit still. It's usually quite physical in nature, like they might say um, either of those things, or that they feel like they're jumping out of their skin, um, or you'll see them in the office or hear from parents that like maybe this had been kind of an active kiddo before, but the degree to which it's present and the subjective experience of it is is usually pretty significant. Um, it sometimes can be a little bit tricky to distinguish from anxiety. So on a case by case intervention, case by case basis, we want to kind of talk through with our patients and with families to try to um, distinguish those as much as possible. Again, of the EPS symptoms, this is the one that we most commonly see in kids and adolescents. Um, if it comes up, first strategy is typically dose reduction. Again, keeping in mind this balance of whatever the symptom was or the underlying diagnosis was that made us start the medicine in the first place. We want to keep the dose high enough to control those symptoms, right? So, psychosis obviously, but even if it was started for behavioral and emotional dysregulation, we want to be careful as we're backing off on the dose that we don't kind of trigger those symptoms coming back. But dose reduction can help kind of limit the sensation of akathisia and the degree of restlessness. Um, if that's not effective, or if in the process of pulling back on the dose, symptoms start to reemerge, then we're at the point where we think about switching antipsychotics to a different one that may be less likely to cause akathisia. Of the ones that I showed earlier that are used fairly commonly, quetiapine is one where the risk for akathisia and for sort of movement disorders in general is lower than most of the other ones. So it's a reasonable one to go to in that vein. Occasionally, we'll use medicines like propranolol or lorazepam or benztropine to help manage the akathisia, but that is typically done um, as a temporizing measure while we're deciding, are we going to switch to a different medicine or can we safely back off the dose, or either one of those. I don't love having patients kind of on these medicines to manage side effects and just holding steady with the current antipsychotic, um, unless we've already trialed a number of other ones, and this really does seem like the only medicine that's clinically effective for this patient. So another possible neurologic side effect is Parkinsonism, right? So you can see this come out as patients getting a tremor or being slowed overall in their movements, or having more of a shuffling gait. Um, Less common in kids and adolescents than we might see in some of our adults who are on antipsychotics chronically, but can happen. And again, the interventions are fairly similar, right? This constant interrogation of where you at in the risk benefit divide with these medicines. Can we safely reduce the dose of the antipsychotic and still keep the symptoms at bay? Um, and then if not, switching again to a medicine that's less likely to cause EPS, with quetiapine as one reasonable option. Um, Benztropine or cogentin, we also use to try to manage Parkinsonism, but again, not something that we want people on chronically. Um, benztropine is not great in terms of cognitive side effects and cognitive slowing, and so try to avoid having people on it, for months or years. Um, and then acute dystonia. So these medicines can sometimes produce dystonic reactions like an ocular gyro crisis, where patients' eyes are stuck sort of looking up, or classically you'll see it as a rigidity in the sternocleidomastoid muscle, where patients may be stuck sort of in this position looking over to one side or the other. Um, this can be quite painful, quite uncomfortable for patients, and they'll, almost always will present for care if this is going on. And it's something that we want to treat acutely, right? So those previous two types of neurologic symptoms, we have a little bit of time. They're not typically super progressive. But with acute dystonia, we want to get them treated emergently, like having them go to the emergency room. You typically get an either IM or IV Benadryl or benztropine, and that can really relieve the symptom quite quickly. And once that initial dystonia is resolved, then we can go into the usual steps of, seeing if we can back off on the dose, seeing if we need to change medicines to try to prevent this from recurring. But acute dystonia is one of the ones that we want to treat urgently and get them seen quickly and get it resolved. Um, it's not very common, but if you see it, we want to take it seriously, and knowing that in some rare cases, so rare within an already fairly uncommon side effect, but it can involve kind of muscles that support respiration, and so there is a risk of death with it. Okay. And then tardive dyskinesia is even less common in children and adolescents, but it is important. So I wanted to spend a little bit of time talking through it today. So tardive dyskinesia is sort of an involuntary movement of, classically it's tongue, lips, lower jaw, and then extremities, so hands and fingers. Um, Often in like a affetoid or chorea type motion, or like a tongue flicking. You may see when they're not paying attention to it, the patient's tongue sort of emerging from their mouth, or their jaw moving, or lip smacking. Um, the main risks for this are chronic antipsychotic use, so often on the order of decades, um, years if not decades, and also antipsychotics that are used higher in the dosing range. So the most common times that we'll see tardive dyskinesia are in patients with chronic schizophrenia, who again have been on these medicines for a long time. So that just by nature of their ages makes it less likely in kids and adolescents. But if you do see this, we want to get them evaluated, whether that's through talking with their psychiatrist or having them see a neurologist to evaluate the movement disorder. Um, Again, we back off on the dosing. We think about changing medications um, to a different antipsychotic that may be less likely to drive this. Um, I put up here just as a reference the Ames scale, not expecting anyone to read this or go into detail about it, but just to know that there's this scale that is mostly, you do it mostly through observing patients, right? So as they're just sitting in your office, you can um, see if any of these movements are present or absent. Um, and at a minimum should be done at baseline, and then every 6 months or so. Psychiatrists should be doing these if they're the ones prescribing the medicines. But again, I put it here just as a reference for if you hear a complaint from a patient that they're having some kind of atypical movement, this can give you a framework for evaluating it. Okay, then to switch gears a little bit to endocrine system. So hyperprolactinemia, elevated prolactin, is a possibility with some antipsychotics, most commonly with risperidone and then paliperidone, since paliperidone is a metabolite of risperidone. Um, Symptoms can include gynecomastia, galactorrhea, uh, disruption of menstrual cycles, and changes in sexual functioning. Um, if patients present with those symptoms and they're on one of these medicines, then I'll check a prolactin level. Um, I don't check it routinely, even for patients who are on risperidone or paliperidone. Um, uh, because if they're not symptomatic and the level is only kind of mildly elevated, there's not um, necessarily changes that have to be made. When I've talked with the endocrine folks in the past about this, they have sort of prioritized clinical stability in terms of the psychiatric symptoms. Um, and then but again, once symptoms of hyperprolactinemia do occur, then we might think about adjusting the regimen. So uh, not checked routinely, but if symptoms are present, then we'll check a lab value. And really like a level that's like triple the upper range of normal is where we start to be more concerned. Um, Non-emergent, you can make changes to their regimen over time. Um, those changes might be, uh, again, reducing the dose that they're on, um, changing the antipsychotic that they're on off of risperidone and paliperidone, which are the most likely to do it. Um, for some patients, we add a low dose of aripiprazole. So aripiprazole is a partial agonist, partial dopamine agonist, and so adding a low dose of aripiprazole can actually um, allow some more dopamine signaling to go through, and then prolactin levels to normalize a little bit. And we might do that in instances where risperidone or paliperidone has been the only medicine that's kind of worked clinically to help stabilize a patient's symptoms. Um, and or we might do it as the start of a gradual transition from one of those medicines over to paliperidone. But that is in general, I really don't like to have patients on more than one antipsychotic at a time unless I'm in the midst of crossing from one over to the other. But this scenario is kind of one of the exceptions to that. Okay. And then um, before we talk a little bit more about kind of how we co-manage these symptoms between the psychiatrist's office and the pediatrician's office, I wanted to just bring up a few other ones that we see. One is sedation. It occurs fairly commonly with antipsychotics, particularly as we get higher in the dose range, right? So, you know, if we're starting these medicines for a patient who's very dysregulated, we might take a little bit of sedation in the beginning and accept that in the with the goal of kind of keeping them and everyone safe. But long term, right, we don't want kiddos to be so sedated that they can't be in school, they can't be doing their work, they can't be living their daily lives. And so uh, I ask patients about kind of level of energy, level of tiredness every time I see them if they're on an antipsychotic. And again, think through that balance of kind of how much medicine do we need on board to control symptoms versus exposing them to more side effects. Um, Emotional dulling is somewhat related, a little bit harder to measure, but sometimes families will come in and say that they just don't seem like themselves or that they've lost their joy or their spark. Um, Again, this can happen as if doses are higher than what the patient needs. And so kind of backing off on the dose of the antipsychotic is a first step, but if not sufficient, may be a reason to switch from one medication to another. Um, Atypicals can prolong QTC, right? So if I don't, we don't get EKGs at baseline for most patients, but if there's a family history of arrhythmias, if the patient's on other QTC prolonging medications, or the patient themselves has had cardiac abnormalities in the past, that would prompt me to get one at baseline and then to check it again once the patient's been on the medicine for a period of time. Um, so not for every patient, but I wanted to bring it up here so that you know if you have patients who have other risk factors for QTC prolongation, then it merits a little bit of closer look for patients who are going to be starting on an atypical. And or having them see cardiology, depending on kind of the degree of concern.
Do
And then finally, neuroleptic.
Yosh, if someone is prescribing Geodon, would you routinely recommend EKG sort of screening in advance of prescribing that?
Um, it's possible. I think like Geodon, as we've talked about, is not one of the ones that we would go to quickly. So by the time I get to Geodon, I've often had an EKG for one reason or another for patients. Um, I still don't think it's like it's 100% necessary, but if it would probably make everyone feel a little bit more comfortable if we've checked an EKG beforehand. So um, I don't think inpatient units will always get an EKG in patient psychiatry units before they start somebody on Geodon. But when we see them in follow up in the outpatient world, we might want to think about doing it to just get a sense of where they're at.
Great. Thank you.
And then neuroleptic malignant syndrome, NMS, very rare, but can be life-threatening. So again, I'm bringing it up here. Um, that NMS can present with symptoms like being febrile, having muscle rigidity, having autonomic instability, and altered mental status. And so this is a reason to be in the emergency room and then likely um, in the PICU for management of it. So again, incredibly rare, but important to recognize if it does present in your office. Okay. And then just a word about co-management. So psychiatrists should be paying attention to all of these things that we're talking about, particularly when they're the ones prescribing these medicines. But as we saw with the data from early on in the presentation, lots of patients will be on atypicals without connection to a psychiatrist. So whether these medicines are being started in your office or um, patients were started on these medicines on an inpatient psychiatric unit and then discharged to you as the prescriber because there just wasn't availability of a child psychiatrist, um, you know, and because uh, parents will often come to pediatricians first with some of these side effects. Um, the monitoring intervention for antipsychotic medication is kind of a perfect co-management scenario, right? And especially um, for a MCPAP, like we are happy to have phone calls, see these patients for consultation, think through, okay, what was it that prompted this patient getting started on an antipsychotic in the first place, and then, excuse me, and then given the side effect uh, that's coming up, how would we think about adjusting their regimen? So again, MCPAP is here, happy to um, partner with you around managing these, but also wanted everyone to be kind of aware of what to look out for when these medications are in play.
Hey,
Uh,
Michelle, I was gonna to that point, which I think is a really good one, and I'm so glad that we're talking about co-management. Is I should sort of acknowledge that out in the world, outside of our offices, there's a lot of people, a lot of different specialists, who are seeing the kids, that might need, this kind of medication. And so, the point that you made, about, the role of antipsychotics and how we don't sort of like to use them, liberally, and, for things that really don't require, an antipsychotic and aren't significant, sort of kinds of problems like sleep. Sleep is significant, but, obviously antipsychotics are not, the treatment of choice, for sleep disturbances. But, as pediatricians, you will see, or pediatric primary care providers, you're going to see people on antipsychotics, and if you ask them, sort of ask parents, and kids, what the indication has been, you might find out, that it's not really appropriate, and so, there is a lot of just in practice out there, a lot of overuse. We see a fair amount of overuse of antipsychotics, and so I think that would be an appropriate reason to, kind of contact the provider and raise questions. You can contact us, in MCPAP, and we can talk with you about it and sort of give you some ammunition, for those conversations. And but I think that's an important part of the role, as far as just being kind of a check on the system, and so being armed, with, some knowledge about best practices really can be really helpful for these kids. Yeah, so go right ahead. Sorry about that.
No, no, that's a valuable comment, and I'll add on to that actually, and just say that we also see with some frequency that it may have been appropriate at the time that the medication was started, but then we want to be vigilant about how long do these kiddos need to stay on these medicines, right? So it may have been that, in crisis, a prescription for risperidone was sort of the only thing that would have helped kind of uh, keep everyone safe and regulate symptoms. But then what we want to have at the forefront of our minds is, okay, that we started it, but when are we going to be able to come off of it, right? And how would we think about the process of coming off of it in a careful and responsible way? I think about for maybe with the exception of primary psychotic disorders like schizophrenia, um, every time that I'm starting somebody on an atypical, I'm also starting the conversation of how will we know when is it time to taper off of this, right? So that um, children and adolescents don't just get stuck on these medicines for years, right? And that we can be actively kind of engaging with them and with parents around the question of how long to stay on it, how long to stay on this dose before we start to taper. Right? I think that's a kind of deprescribing as an important part of the role as well. And again, MCPAP can be a part of that conversation as well.
Yosh, it's John.
Yeah.
Just to remind folks, particularly for the kids with autism who may be put on antipsychotic for their behavior, just to remind people that we have this relatively new service where you can call and we'll have that kid evaluated by a BCBA, um, ABA expert to see if there's some way we can modify their behavior in the environment rather than depend upon the antipsychotic. So that's a really nice service we can offer families whose kid is on an antipsychotic for around autism.
Yep. Good. Okay. So that was the end of the slides I put together, and so I'll open it up and see if other folks have questions or comments or other things for us to talk through as a group.
Well, thank you so much, Yosh. It was really, really nice, nice talk. And I'm, I don't see any questions in the chat, but I'm curious, as far as how do you guys feel, about prescribing antipsychotic medications or being asked, to consider that? And, it's kind of like it's breaking out of the bounds of the traditional, scope of practice. In recent years, it's become much more, sort of acknowledged, that antipsychotics are needed, for more kids than there are child psychiatrists to treat them. We have more, psychiatric providers, as I mentioned before, but it is, it does kind of like fall upon you, sort of more often, to at least to be asked. And I think we assume, that it might be okay with you, but it's not always okay with you. So what's your thought about that? And that's kind of one of the reasons why we wanted to provide you with more education about this, because we know that you're being asked, more, but we also know that there's no absolute rule. So thoughts about that? Anybody want to share? It's a safe, we want, it's a safe space to kind of open up about any discomfort that you have.
Barry, there's a question in the chat.
I see it, but I want to see if anybody would answer my question first. All right, I'll ask the question in the chat. So Diane Hazel is asking if an antipsychotic is stopped, can we expect weight gain to be reversed automatically, or will these kids need some help to get back to their baseline?
Yeah, I mean, I think it depends on the degree of the weight gain, but for those kids who have put on the, 20, 25, 30 pounds of weight, they'll probably need some support in terms of getting back to their baseline BMI.
Ah, yep. Yeah, that's been my experience too. So Hillary, hey Hillary, it's been a while. I see that you are asking about I guess the question that you bring up is kind of related to the point that you'll see kids on antipsychotics, and the psychiatrists should be monitoring their own treatment, and sometimes they're not, and so it's kind of like a joint sort of responsibility, although it is, we consider it to be kind of a failing of the psychiatry role if you encounter patients who are not being screened for metabolic syndrome when they're on an antipsychotic. So is that sort of more of a comment, or is there a question about that? I know the mic unmuting um, didn't
Well, I
work for
guess a
you.
natural question might be, what do you do in those circumstances?
Yeah,
And
yeah, yeah.
I think that can range from, speaking to the family and asking them to talk to their psychiatrist and ask about, I hear that we're supposed to be doing XYZ monitoring. Do we need to do that, et cetera? And or, communicating directly and encouraging them to do it. And then I suppose worst case scenario, even though it's not that bad of a case, but would would be having the pediatrician do the lab ordering. Again, I agree with you, Barry, that this should be the psychiatrist, psychopharmacologist, whoever's prescribing that is monitoring, but we don't, it's not 100% fidelity around that.
Yeah. Yeah.
What we see a lot as PCP is that when there's transition of psychiatrists, because for whatever reason the psychiatric left, we're left with these kids that are in antipsychotics, and then we're left to manage them until they're able to find a new psychiatrist in 6 or 12 months, and sometimes 18 months.
Yeah.
Yeah.
So that's
Yeah.
clearly, I mean, I think that's why we have MCPAP, that's why, sort of pediatricians, are and pediatric primary care providers, are finding themselves, needing to, really learn more about, psychiatry and stuff like that, is because the system is, not serving our kids well, and you guys are kind of like the safety net, and the default, sort of resource. And, we want to work together with you, to try to address the needs of these kids. But it's, that there's an additional text from Hillary about the prolactin level, being high, and so I don't know if you want to reiterate.
Yeah, sorry, I
Like,
can
yeah.
talk now. I don't know what was up with the
Oh,
mic.
good,
I thought
good.
maybe you guys had muted us all, and I thought, oh, maybe it's not mine.
Oh,
Yeah, so right, frustration with following some kids. I've never seen a lab drawn, and I
Yeah.
thought this child was blasted with antipsychotics, and So I checked labs, including a prolactin. I mean, he had never had anything done. I can't remember why I added the prolactin from my note, but it's 100 and he's an 8-year-old boy. So I know theoretically, maybe I can't remember if he had some symptoms while I checked it, but if he doesn't have symptoms, it's not good. Probably, I think with bone health, to have your prolactin be cranked up all the time. So I was going to try to decrease the dose. And I'm trying to get him a psychiatrist. It's mostly the parents' fault.
So when you start to try to co-manage without, being able to communicate back and forth, it can be sort of problematic, in a sense, like if you're changing the dose and then they see the psychiatrist and the psychiatrist doesn't know that you changed it, and then they're, not on the same page and they have to do the med rec and figure it out. But anyway, it's, we did talk, or Dr. Kaneko was talking about the fact that we don't necessarily screen for elevated prolactin unless there are symptoms. So we don't find fault with someone not checking prolactin, sort of, as a preventive measure. But as far as if you happen to get one and you see it being elevated and it's asymptomatic, then you have your own sort of clinical judgment about whether or not you're comfortable with that. We tend not to check it because we would be comfortable, if someone had a prolactin of 100 and we didn't know about it and they were asymptomatic. I don't think we would be concerned about that, but that doesn't mean everybody has the same view. I don't know if you want to speak to that, Yosh, and then I guess we have to stop too.
Yeah, I think the other, if I see a level like that it's unclear if they're symptomatic or not, I might involve endocrine in that discussion too, and kind of get their sense of what are, 100, is 100 meaningfully different than their prolactin being elevated to 50, et cetera, and get their thoughts on that. And combine that with a discussion with the family of like, was this medicine really the one that, this kid was being hospitalized over and over and over again, and then that cycle has been broken with this medicine, and our parents terrified of stopping it versus this is the first one that they've tried, and it might be very simple and safe to switch them over to aripiprazole, or to add a little bit of aripiprazole to bring the prolactin level down.
Yeah, I'm just worried about symptoms in an 8-year-old boy. He doesn't have his period. He doesn't have breasts. So I'm not sure you always, and I know it can affect bone health. So it's just a little, I don't like the idea of sitting out there. So he might, I don't know. It's sort of weird in a boy.
Yeah, I mean, we don't sort of disagree with being concerned. It's more just that, we don't have kind of necessarily, sort of a clear, sort of absolute, sort of concern about, the risk, even in a pre-pubertal male, child, but it's still the endocrinologists, we might turn to the endocrinologist to kind of help us to, sort that out, with them. But again, we are not, our guidelines do not recommend checking prolactin, routinely, for every child who is being prescribed, an antipsychotic, simply because, we don't feel like there's strong enough evidence that we would treat, just an abnormal lab in the absence of clinical symptoms. But if someone is having signs of any gynecomastia or galactorrhea, then, we're certainly, right, all over that. But in any case, we have to stop, and sorry that we went over, folks. But people, we're always free to leave. We didn't capture you to, and hold you here against your will. But thank you so much for attending, and we look forward to seeing you next month. And Dr. Kaneko, thank you so much. It was a really nice talk, and we really appreciate it.
Thanks for having me.
Okay. All right, bye, everybody.